I am very grateful to be here, so thank you, Leslie. Really privileged, and Leslie and I chatted many times very early in the morning about a concept of what we thought we should put together here, and I'm really privileged to be joined with Dawn Whitten, who's going to speak after me. Leila Mason, I knew I was going to get it wrong. Leila Mason is going to speak about paediatrics. Alyssa Song, who's also going to join us and speak about paediatrics, and Jason Horolak. And all of us are going to try and put together the concept of the immune system with the microbiome through the life cycle. So I get the lovely privilege of being able to speak about preconception, pregnancy and labour. And when I put the notes together, I have to be honest, may have gone a little bit over the top. But nonetheless, I divided it up hopefully at the break point, but if not, I might continue going on and then we'll just have the break and we'll work through it. But nonetheless, there's a fair bit of content to get through, but I figure if not, you can read through it later. So let's get started. So this morning, my 5-year-old decided to ask me, so what are you doing this afternoon? Are you going to a meeting at the uni? And I said, well, sort of. I'm going to the uni, and thankfully it's the same place, but I'm going to speak at a conference. And he wanted to know what it was that I was talking about. So me cooking breakfast, it was snowing, I have to tell you. In the Blue Mountains this morning, it was snowing. That was pretty cool, which is why I keep taking layers off this morning, this afternoon. And he was trying to understand the concept of, so a sperm and an egg, and how does that work? And then what do they do? And then how come the health of them makes such a difference? And why are you doing this, and why do you want to talk here, and what are you actually doing this all for? And I said, because if it can help other kids be healthy like you, why shouldn't I? And the idea was, it was quite simple, and it was a really nice way as a prelude for today, because it helped me sort of look at it in the context of why are we actually wanting to do this. Fundamentally, we're going to talk about this whole journey of the microbiome across the life cycle, and the ultimate goal is to make healthy children. The ultimate goal is to help the parents be as healthy as they can be, to improve the epigenetics, as Warren was beautifully describing earlier. I'm sorry I wasn't here, James, but I'm sure yours was great too. But nonetheless, let's get stuck into it. So we've got this beautiful journey. I'm going to try and do two at once. We'll see how that goes. We've got this beautiful journey that we're going to touch on today, and these are the points that I'm going to cover, and then there are going to be other people that will cover the other aspects. Now, the microbiome in reproduction, bear in mind that this is specifically looking obviously at the female. What we're looking at here is that the microbiome affects absolutely every single aspect. And I know as a clinician, I would always say to people, I don't have the research for it, but I'm absolutely certain that something that the father does is significantly going to impact the microbiome of the mother. And luckily, we now have a bit of research to prove it. Absolutely every single aspect will be influenced by the microbiome. So the health of the mother, the health of the father, at every single stage of that pregnancy will have a role. Even just the father, him lying next to the mother, and what's coming through his skin has been shown to have a role on the mother and her likelihood of having a miscarriage or having a preterm birth. And we'll go through all that as we go today. So from gametes to fertilisation to embryo migration to the ability of actual implantation, the microbiome is what's actually controlling that. So it's all very well that we sit there with a woman and she's got a shortened cervix in second trimester and she's about to deliver. It's actually the microbiome that's responsible for that. And it's the microbiome that affects the stress, as Warren was talking about. It's the microbiome that allows these ascending infections and allow the cervix to open. It's the microbiome that makes that baby born and be too early. What are we not understanding here? There's a lot that we'll talk about, but there's a lot that we don't know. And I want you to just, if nothing else, get a lot of questions from what I talk about today. Now, let's talk about the guys first, all right? Now, the guys is one that I think as clinicians we've always known that there was something going on with the guy, but we couldn't really work it out. And I think that the IVF community have a lot to answer here, because the IVF community go, you've got sperm, they swim, you're fine. We have a society where, men certainly in Middle Eastern countries, they all get ICSI, so they all get where the sperm gets injected into the egg so that there is no disrespect to the male. The male is, he produces the sperm, he's done his job, yeah? We know in this room and certainly in this community, we know that there is a lot more that the male actually does. And what's fascinating is that we now understand is that healthy sperm are actually swimming in lactobacilli species. We know that they have a lower bacterial concentration than the vaginal microbiome itself, and we know that they do have lots of other species there, but the richer it is in lactobacilli species, the healthier the dynamic, the easier the conception, and the easier the pregnancy. Don't underestimate how difficult a pregnancy can be if the male gives sperm that's been sitting in unhealthy semen. The microbiome of that semen will influence whether or not she has an infection, will influence if she gets morning sickness, if she has spotting, if she has early loss, or even if she has preterm birth. And that's because he introduces an infection very early, and then what mechanism does she have to actually eradicate it? Low quality semen, we know, is associated with all these wonderful, hard to pronounce terms, all these species listed there. Little caveat, my last slide gives you a list of all the taxa in pregnancy. So when I talk about groups of species, just so you have the little cheat sheet, it's the last slide. Healthy semen, as I said, is predominant in lactobacilli species. So very, very, very important to sort out the microbiome of the male. Remember that the semen is a byproduct of the body. Similar to urine, to feces, to saliva, it is a byproduct. Everything that he exposes his body to is what comes out in that semen, which means he's equally as responsible. We cannot keep blaming women for miscarriages and assuming that it's just her fault. There is equal share in this. 50% of the genetic material, 50% of the initial microbiome is because of the father. I found that quite revolutionary, to be honest, when I saw it. Now, this I think is quite fascinating. So this is actually research that's been done in the IVF communities, because you have situations where you have an IVF scenario and you have washed sperm that goes and gets injected into an egg, and you wonder why it actually doesn't fertilise half the time, yeah? So what they're now starting to realise is that that sperm was originally swimming in something called semen, and that semen may have actually had a role to play in the equation of what made a baby. Funny about that, yeah? So the semen itself, what we now know, they did a meta-analysis, bless them. Meta-analysis, groundbreaking. Sex during IVF improves implantation. Is that not groundbreaking? Do you not feel that's groundbreaking? I read that and I was like, you have got to be kidding me. So obviously I have lots and lots of patients that are in the fertility community, I should say, hopefully the fertile ones, in the fertility community, and all IVF specialists say to them, don't have sex. Now the reason they say don't have sex is basically legal, is basically an insurance risk, but they also say don't have sex because they don't want you to have multiple conceptions, and they also say don't have sex once we've collected the eggs, because then you might actually fertilise one of those follicles that we really didn't want to do anything. I mean, what is that? The amount of patients that I've had that have triplets and quadruplets actually, and they know that some of them are from the IVF pregnancies and some of them from them having sex straight after being collected from the small follicles, and they know that which child is a natural versus an IVF. I think it's quite interesting. Anyway, I digress. Now, the exposure of the seminal fluid to the vaginal microbiome determines if she conceives. Without semen, she doesn't have the immune receptivity to his sperm. She has an immune reaction against the sperm and she fights against it, and she doesn't implant. So the amount of patients that you'll have that will go through IVF and they don't have implantation, maybe it's because they're actually having a reaction against him and their immune system is reacting against him, and we need to address that. There is a new therapy that's come out, which I'll talk about a little bit later. But anyway, they basically take the lymphocytes from the dad and they inject it into the mother so that her immune system doesn't react against him. And the reason behind why that works is because she's not getting the lymphocytes from the semen. Something to think about, yeah? And something to think about in the context of post-sex, the semen, what is it doing and how is it affecting the female and how is she receiving the sperm, and actually enabling fertilization. Anyway, enough about the guys. Let's talk about the mum, because there's a lot more going on here. Now, I do need to give you a little caveat that you are going to have a lot more discussion about the maternal microbiome with the other speakers today, and we're just going to all reiterate the same concepts, but just bear us in mind. So, the maternal microbiome, what we're looking at here is the cervix, the gut, the uterus, the placenta, and the vagina. Every other part of her body is equally as important, but these are obviously the most important ones, because any disruption to these areas will actually produce adverse pregnancy outcomes. And you're all sitting there going, yeah, but the gut, how does that correlate? We're going to go through all of that in a moment. Now, the vaginal microbiome, you may or may not be familiar with it at this point, but anyway, you will after today. The vaginal microbiome is basically 90 to 95% of lactobacilli species in a healthy vaginal microbiome. It's absolutely vital and absolutely essential that we encourage this species, because they are what actually protect the vagina, enable it to have the pH that it has, which then protects it from further infection. There are a whole host of other bacteria present in the vagina, but the lactobacilli are the ones that you want to focus on. Now, there are lots of different factors that will influence the vaginal microbiome, and they're listed here in this fantastic picture. Some of the things that you may or may not remember is obviously age. What happens to the vaginal microbiome as she ages? Her estrogen drops. As her estrogen drops, her lactic acid production and glycogen absorption drops, which means her lactobacilli strain species drop, which might be why more older women who conceive later actually have a higher chance of bacterial vaginosis or have a higher chance of miscarriage. Other things to think about, obviously, when she's pregnant, we all know the pregnant woman who has lots of cervical secretions. The endometriosis women tend to have more of it because they're more estrogen prone. We know that diet and lifestyle certainly are going to affect it. We know that sexual activity is going to affect it. And don't just limit it to obviously exposure to semen and sperm, but certainly consider lubricants, sex toys, whatever they're doing in the bedroom. All of that is going to disrupt that ecology. Menstruation, we know, is obviously kind of like a reset for women. It tends to clean out the microbiome to a certain extent, and the blood pH will influence it quite significantly. Smoking is obviously not beneficial. Exogenous hormones are not an ideal, and hygiene practices. The amount of women that still purchase those vaginal hygiene products and douches and all that stuff still astounds me, but nonetheless, it's not a good idea. And I don't think Ron's in the room at the moment, but there's lots of slides just for Ron Ehrlich. Oral microbiome. We're going to talk a lot about that and how it influences the vaginal microbiome later. Now, there is a significant variation in vaginal microbiome in different countries around the world, but the 4 main strains still prevail, but it's the percentage of those strains that you need to factor in. So over on the left is an Asian community, then white, black and Hispanic, and you can see that the differences in them is quite significant. And you know, if you look at the white one, only because most of the studies are done on white people, you can see that the Crispatus species is actually the most predominant in the white population, which is actually detrimental to pregnancy, and we'll go through that later. So I think that diet has to have a fair amount to do with this and will influence the types of microbiome present. Am I going too fast, or you're all with me? All good? Great, there's lots to go. So, when you have a pregnant versus a non-pregnant woman, the pregnant woman actually has a more stable vaginal microbiome because the species tend to reduce over time. It gets more and more concentrated in lactobacilli, and the changes between the first and the third trimester, they tend to decrease. So we get more concentration and it becomes more and more protective. The role of the lactobacilli species is to protect the whole vaginal ecology to prevent ascending infections. If she doesn't have it rich in lactobacilli strains, she's more prone to getting infections, and obviously bacterial vaginosis and all that stuff tends to prevail. Obviously, the estrogen production that follows conception, which I alluded to just before, it promotes the glycogen production, which improves the vaginal epithelial cells, and it then enables more metabolism of the lactobacilli themselves. So you want your female patients to have a surge of cervical fluid in pregnancy. You don't want it to be copious that they're having to wear sanitary pads every day, but you do want them to have a surge of it because it tells you that there is more estrogen, there's more protection, and there's more helpful production of lactobacilli strains present. If you look at this table, this is an interesting table where they did a comparison of women where they had first conception versus subsequent conceptions. And what I found quite interesting in this study was that what they found was that there was a significant change in the concentration of the lactobacilli species depending on if they had prior birth or not. The authors had various conclusions around this, but what I took from it was that certainly the nulliparous woman, or the woman that's never had a child prior, the Crispatus species is certainly more predominant, and then it reduces with subsequent pregnancies in preparation for the next pregnancies. And that helps to reduce her miscarriage risk and all that sort of stuff. If we go further down, pardon me, further up, ignore that one, and we move towards the cervix and the uterus, there is not a lot of data when you start looking at some of the more sub-specific areas of the female reproductive tract, but wanted to show you where the research is at the moment. So as of, where are we at, 2018 and 2017, the species in the cervix and the uterus, they do believe that they colonise quite specifically in the tubes and the ovary. They certainly colonise in the fimbriae and the ovarian surface, and uterine biopsies of non-pregnant women, again, the similar lactobacilli species as well as other bacteriophile types. But what I do think is quite illuminating is in patients when you have tubal patency issues. I don't know if you see this in your own practices. Obviously, the type of patients I see a lot. Whenever I work on the microbiome, even if it's just digestive microbiome, I have, at this point, been able to unblock most tubes. And one in particular at the moment where she was left with only one tube, and even if it's from an infective course and she had surgery to remove the other one and the ovary and all this sort of stuff, by purely working on the microbiome we were able to unblock her tube, and we're in the phase where she's hopefully about to fall pregnant. So, lots that you can do. Don't underestimate the lactobacilli strains and their impact to the fallopian tubes themselves. Now, the assisted reproductive community, so the IVF community, has lots that we can be grateful for, and if nothing else, it helps us understand the reproductive ecology in a different context. So I wanted to highlight a few of these different studies here for you, because you're never going to get access to the tissues in a pregnant woman, of course. So what we understand at this point is that implantation absolutely requires microbial colonisation of the upper genital tract. What we understand is that without appropriate colonies present, implantation never happens. When you look at the vaginal microbiome in IVF, on the day of embryo transfer, if the vaginal microbiome is inhospitable or unhealthy, implantation does not happen. This is proven across the research in the IVF community. It's just not very shared, because they never want to sort of say, oh, well, you could go and take a probiotic or do something about it for whatever reason. The success is most likely correlated in all the research that I've seen that if a woman has optimal lactobacilli strains, implantation is obviously a lot greater. So it's something to be thinking about both in natural conception as well as IVF conception. And I think perhaps an aphrodisiac should be a glass of probiotics. When you look at the IVF community or the ART community, bacterial vaginosis, they know, is much more prevalent in infertile women than fertile women. And they know that there is an association with preclinical pregnancy loss and decreased pregnancy rates in IVF patients. So as soon as they can detect bugs that are present, they know that they're going to have a bit of an issue. I have a bit of a concern with this only because in about the 1990s, early 2000s, there was this surge of every IVF specialist thinking that the holy grail was if we treat mycoplasma and ureaplasma, and they were swabbing all women and men, and they were looking at it and treating it, and then all of a sudden it didn't become fashionable anymore and they stopped it. The pros and cons. So the pros were that they were realising that if there was an infection, it affected implantation. Great. We can look at that research, and even as recent as 2013, they're still doing studies on it, thinking that it's appropriate. The cons are obviously that they were all given antibiotics, and then that's probably why they felt that it actually didn't work, and that's why it no longer became fashionable. And again, the cons are that they probably had higher chance of miscarriage. Does it mean that you should look at for any swabs or anything along those lines to check if there are infections? Absolutely. They did always prove, though, that when they treated it, they had higher pregnancy rates, but when you look at the research, they actually had higher miscarriage rates subsequently. So bear that in mind. Now, the ovaries themselves are actually surrounded by fantastic microbiome. So we've got the peritoneum and we've got the peritoneal fluid throughout the entire abdomen. And when you assess the peritoneal fluid, that has its own type of microbiome, but it's affected by bladder strains and digestive strains and all of that as well. When you're just looking at the fluid around the ovary, we know that when it's richer in lactobacilli strains again, that there are higher chances of embryo transfer rates. So again, more lactobacilli, more lactobacilli. The endometrium, one that I'm particularly attached to research it with because of my interest in endometriosis, we know that with women with endometriosis, again, if they have higher lactobacilli strains, they will have a much higher chance of pregnancy outcome. If they have lower lactobacilli strains, or if they have Gardnerella or Streptococci present, the chance of them conceiving is much, much more reduced. It's very, very important if you have any women with endometriosis that you address the microbiome, and you address it through the peritoneal fluid, so that you address all of the microbiome systems, shall we say, throughout the body. And also, when you look at the data around endometriosis and treatment, it's a bit conflictual about the antibiotic treatment because it tends to have a rebound effect, and that's obviously because of the rebound to other subsequent systems, namely the digestive system. Okay, so hopefully we've got them pregnant, but unfortunately they're now miscarrying. So what can we do to actually prevent it? So this was some of the information that I was alluding to earlier. This is looking at lymphocyte immunisation therapy, where they've been doing this actually since the 1980s in the US of A, where they were looking at repeated spontaneous abortion patients, which they believe is 1 to 3% of the population, and they've been doing this type of treatment for a very long time. They've now brought it out that it's the latest craze. I don't know if anyone in the fertile treatment world is finding this. Every woman walks in and she's seeing a particular doctor in Sydney and she's having this process, and everyone thinks it's the holy grail at the moment. But anyway, what they're doing is they're basically taking lymphocytes from the father. If she's using a donor, it's a bit trickier, obviously. and they're trying to reduce her immune reactivity to the partner. What I would like to ask here is perhaps we should just fix the microbiome in both parties and perhaps we'd probably bypass it. And I certainly see that in patients of my own, but I have one couple at the moment that are adamant that they're doing this, so I'm going to watch and see what happens. I'll let you know. Now, NK cells were certainly big in the fertility world. It's dying down a little bit, but it's still rumbling in the background. But anyway, we certainly know that if there are increased elevated levels of peripheral natural killer cells, the chance of miscarriage is certainly greater in the female. When you look at the research, which is not what they're actually discussing when they're treating the natural killer cells, it's generally all about Gardnerella, more so than anything else. And the Gardnerella tends to disrupt the microbiota quite significantly, changes the immune parameters, increases chance of miscarriage and inflammation, and all of that. So natural killer cell treatment, are you guys seeing it in practice? Do a lot of people work in fertility in the room? I should actually ask that. Handful? Handful. Okay, I'm getting quite specific then. So when you have a patient with natural killer cells, they do a blood test and then they also do a biopsy, and the standard treatment is to give corticosteroids, antibiotics, and blood thinners like Clexane. It used to be called the Colorado Protocol. It's now called the Bondi Protocol after Gavin Sachs. It's pretty intense type of treatment. Certainly in some patients they do get results, but these are for people that have, copious amounts of miscarriages, and I think it would be interesting to actually treat the microbiota and actually fix that rather than giving them all these fairly strong toxic drugs, and that might be the answer. Anyway. Now, the next topic that we need to talk about is bacterial vaginosis, which Jason is going to talk about quite extensively as well. So I am going to go through it, but you'll get a lot more afterwards. How many of you are seeing lots of bacterial vaginosis in clinic? Fair amount? Yeah. Okay. So it's one of those ones that I think a lot of clinicians find quite tricky to treat at certain times, or some people just have answers and it just works beautifully. It's very, very, very common, and specifically it's very common in the pregnant woman, and if she has BV, she tends to have a much earlier chance of miscarrying, or she has a preterm birth. It's definitely something that you want to address, and mainstream medicine tend to address it by giving copious amounts of antibiotics, as well as topical antibiotics, which tends to disrupt the microbiome further, which is obviously a concern. But it's a shift in microbiome constituents, which tends to increase the demand and increase their exposure to something that's going to cause them harm. In some situations, BV can certainly prevent them from actually conceiving. So it's something to always look for and something to investigate. When you're looking at it, it can happen in early pregnancy, and if it's in early pregnancy, it can increase the risk of miscarriage, as I said, but there's a 5-fold increase in late miscarriage, okay? So we're dealing with miscarriage after 18 weeks as very early preterm birth. So yes, babies can live from about 22 weeks in NICU and things like that, but that's certainly not something we want to encourage in our patients. And certainly, it's a polymicrobial infection, and the level of inflammation that's present there is quite significant. I'm going to do a little caveat, but some of the stuff that Warren was talking about with respects to methylation and those sorts of variables, if methylation isn't working, you'll always have higher chance of inflammation, which will give you subsequent increase in infective risk. There was that great paper that came out in September last year. If anyone wants a reference, I can pass it on. But don't underestimate some of the methylation gems that you were passed on earlier, so you can actually use them really successfully. There was a really large cross-sectional study that showed that BV in second or third trimester, people had a 40 to 84% chance of a higher risk of preterm birth. 84% chance, yeah? So this might be a part of people in their pregnancy care that they're forgetting or ignoring. I think it's something that we all need to be screening for. Certainly I don't think that you should be doing too many swabs for the pregnant woman during her pregnancy, but definitely preconceptually, and then maintaining a healthy vaginal ecology is something to encourage. Now, incompetent cervix is one I mentioned earlier as well. It's one that people tend to look at in a clinical context and throw their hands up and go, just have bed rest, yeah? Go on steroids, do all sorts of things, have bed rest and don't do anything. All the new research is pretty astounding that what they're finding now is that a short cervix obviously is, it increases your risk for preterm birth, but an increased tendency of having lactobacilli iners, a dominance of it versus the crispatus or any of the other strains, it significantly increases the risk of short cervix and significantly increases the risk of preterm birth. So this I find quite interesting because you have a woman that's there where her cervix is shortening, and the cause behind it is because she's got the wrong microflora and she's got an increased tendency towards having an ascending infection, and that's what's causing the baby to be delivered prematurely. That's quite astounding, certainly from my perspective. Ureaplasma, Gardnerella, highest types of species that are associated with it. But if you have any patient sitting in front of you and they're like, oh, I don't need to do swabs, don't leave me alone, it's all fine, you have to do things like this because there's too many infections out there that will cause all of these sorts of problems. Little caveat over here, when you're doing swabs, do that for both couples. The guys can't get off the hook because otherwise they share and care infections, and the sharing and caring is increased if he's not circumcised. So be quite insistent on it. Now, the cervical vaginal health itself, there's an enormous amount of microbes that will have an invasion into the amniotic cavity. So just because it's going to be lowered down doesn't mean it's not going to go up. And bear in mind that whilst at the moment we're a little bit on the, we're undecided as to what passes through the placenta, pretty much all the evidence at the moment is conclusive that everything is passing through to the placenta and certainly into the amniotic cavity, which is then affecting the child's microbiome itself and giving them an infection in utero with their development. And then when you start looking at the impact to their brain development and their gut-brain axis, and then there's subsequent disease progression, it's a bit scary, it's all bugs. Anyway, Mycoplasma, Ureaplasma are the two most common ones. Certainly Mycoplasma has the most research. Mycoplasma is one of those infections where they did one study and it showed that 94.4% of men had it with no symptoms, which means that all these guys with their semen, they're not only giving them, immune regulation to enable implantation, they're almost 100% of the time giving them Mycoplasma. And then these women are having this Mycoplasma, which then ascends through the whole vaginal canal, through the cervix, through the whole bit, into the amniotic fluid. And then our babies are swimming in Mycoplasma. I don't think we know what that's doing yet. I don't think we have the research yet to understand that. What we know at the moment is it's a slow-growing organism and both parties are usually asymptomatic. She might have a bit of intermenstrual spotting, she might have a bit of dyspareunia or a bit of discharge, she might have nothing. And more often than not, what I find is I have couples that sit in front of me and they go, oh, look, sometimes it hurts to have sex. And I'm like, let's do a swab. And pretty much 9 times out of 10, they got Mycoplasma. Now, mainstream treatment for Mycoplasma is antibiotics. It's usually azithromycin, so we're dealing with 10 days of a fairly heavy-duty antibiotic. Pros and cons. If you can get rid of the Mycoplasma, that's probably a good thing, and then you fix them after. But certainly don't let them leave that infection, because I think what we'll find in the next 5 years is that it's pretty much guaranteed that an intracellular organism that disturbs the DNA is in the amniotic fluid and affecting our kids. I think we've got to look at it on that level. Anyway, I digress. These are some other infections that might be present. Note, I'm not even talking about Candida today because I think we've talked about it to death through the 1980s and 90s, so I'm ignoring it, but it's certainly an infection that we should be considering about. Okay, so I would like to jump to pregnancy, but we have 5 minutes, so we can either, with Leslie's permission, do break, come back 5 minutes earlier and then go from pregnancy onwards, or I can do a few slides and then break. I'm going for the former. Former? Break now, come back 5 minutes early. There's a lot there. If you want to come back 10 minutes early, I'll take it. Thanks. This study was quite interesting, and what they did is they did a really good image there, obviously, and they look at the non-pregnant woman versus the pregnant woman versus the breastfeeding woman, and the major changes that are going on there. Some of the things that I want to draw your attention to is in pregnancy that the maternal, intestinal, and vaginal microbiome has reduced alpha diversity and species richness, which we've highlighted a few times already, but I just want to kind of get it into your head. The longer pregnant she is, the more specific the strains get and the less diverse they get. The estrogen, the progesterone, and the prolactin increases throughout the pregnancy. They have a huge impact to the maternal microbiome, and obviously as the estrogen increases, the glycogen production increases in the vagina, and then that subsequently increases the lactobacilli strains as well. A few other things that this particular study highlighted as well was that a high-fat diet persistently alters the juvenile microbiome at the year of age regardless of the juvenile diet. So the high-fat diet of the mother, and Warren was talking to some of this earlier as well, really important to have the high-fat diet, but the unhealthy high-fat diet, so the McDonald's version, that's where all the research centres around the microbiome influencing obesity in the little people. And obviously, in this particular one, we highlight that breastfeeding increases the metabolic demand, which Dawn's going to go through in a lot of detail later. Now, this one is where I wanted Ron to be here, but we'll share the slides with him later. This one I found really interesting. And I was always a bit like, you know, that recommendation that you tell your pregnant women, make sure you brush your teeth and make sure you floss your teeth every day, you know, really super important, blah, blah, blah. And we all kind of just gloss over it. Well, what's really illuminating is, wait for it, the oral microbiome and the placental microbiome are identical. I read that and I just went, you have got to be kidding me. So yes, everyone floss all the time. Pregnant, not pregnant. Make your dentist happy. Anyway, let's look at the juicy parts and then we'll get stuck into it. So there are higher levels of microbiomes found in the oral cavity during pregnancy, especially in early pregnancy, which means what I usually always say to my pregnant women is go see your dentist in second trimester only. Don't see them in first trimester, don't see them in third trimester. And I knew why, but now I know even more why. Because in first trimester, if they go and get their teeth cleaned, you're going to introduce all of those unhealthy microbes into their gums, through their system, through into the uterine cavity. Non-pregnant women, pregnant women, certainly the pregnant women have higher levels of unhealthy microbes. Now, oral health itself, there's a direct pathway basically of the gram-negative bacteria that are in the gingiva around the teeth, and then it's a pro-inflammatory marker and it goes straight into where the baby is, and the periodontal disease and gingivitis is associated with preterm birth and low birth weight. So make sure that the women are flossing, make sure that they're using appropriate toothpaste, make sure they're brushing their teeth regularly, and it certainly gets tricky in first trimester when women have really bad nausea to stick a toothbrush in their mouth, let alone brush with anything, but you can navigate that, even if they're just gargling with salt, something, just to clear all the microbes, because all of those are strongly associated with both miscarriage, preterm birth, and low infant birth weight. This is some of the mechanism around why and how it all happens. When you have a look at this at home in your spare time, because I'm sure this is exactly what you're going to want to look at, just acknowledge that there are aspects here that associate the bacteria in the oral microbiome correlating with preeclampsia, correlating with miscarriage, correlating with preterm birth, as I said, and certainly correlating with various changes in the liver in the mother. And there is some new research coming out that the cholestasis in the mother is directly related to her oral microbiome. And if she has the cholestasis, that means that the microbiome for the bub is disrupted. It's crazy, yeah? Yeah. Gets a bit like that. Who knew, but the placenta has a microbiome. Now we have the ability to test for it. Fantastic. What we know, though, is, as I said, that aha moment is that it's most similar to the oral microbiome. So if mum's oral health is healthy, we have a greater chance that the placenta is healthy. And if anyone is still out there thinking that the placenta is this lovely, sterile environment that nothing goes in and nothing goes out and they're not sharing anything, I think this will be evidence by the end of today that there's enough evidence to support that it is obviously sharing. We don't know how it enters. We don't know if it only enters through the mouth or if it ascends through the vagina, but there is some research, this one's scary, that if she has sex and gets an infection through the vagina, that can go into the placenta, which can then change her oral hygiene, so she can get bad breath from having dodgy sex. I know. Thought you'd like that. Okay, E. coli is most prevalent in the placenta, which again I find quite illuminating, and again perhaps that correlates with constipation issues in women because the E. coli goes and transcends over to the placenta. They're not certain yet, but I do think that you need to acknowledge that. Okay. Low species of lactobacilli means greater risk of preterm delivery. That's basically your take-home message from the entire talk today, so you can all go home. But seriously, in the placenta, it's all lactobacilli as well. So make sure that you do enormous work to support that lactobacilli. There is an abundance of all sorts of other species in there, but the lactobacilli within the placenta is what enables and protects it from preterm birth, from atresia of the placenta, from early delivery, from all those sorts of things. Now, the microbiome itself has an enormous amount of influences, but the one that I found most illuminating is a fewfold. There are a number of different factors that will change the microbiome in the placenta and the composition of it, and they're summarised in that visual image over there. The one that I thought was really interesting is that there is certainly a link between the development of gestational diabetes and obesity and subsequent disruption to the placenta. So part of why we certainly also need to protect our women from gestational diabetes and protecting them from insulin surges is because it disrupts the placenta. If it disrupts the placenta, then it's also going to increase the preterm birth risk. Did that make sense for everyone? I've got a lot of glassy eyes, so I'm trying to work out if we're processing. We're all good? All good. Okay, here we go. Now, the dysbiosis of the microbiome and preterm birth, there's a great visual picture here, but you can see on the left that you've got commensal flora, healthy scenario, and on the right it's dysbiotic. And because it's dysbiotic, there's an enormous amount of inflammation, and what that does is it weakens the matrix of the membranes of the placenta. So the placenta itself actually gets disrupted by the dysbiosis of that microbiome. Now, the fetus itself, as you would expect, has its own microbiome, and the fetal and neonatal microbiome most closely, as I said, resembles the oral and the placental microbiome of the mother. So mum's health of teeth tells the placenta what to have, which then tells the baby what to have. So again, we're flossing, yeah? So what you can see here is the difference between, on the left, the 1 week postnatal in a healthy scenario versus an unhealthy scenario, and the differences and the impact to both cord blood, to the placenta, to the amniotic fluid can all be attributed to the original infection in the oral microbiome. It's pretty full on, hey? Yeah? So I always was telling my pregnant women, now brush your teeth with pink salt and, you know, do all this stuff. And again, it's getting more and more justification for why I was doing that. And I think that as well, look in the bottom section and you can see the differences in the microbiome in the neonate, and certainly in the healthy scenario, they've got that Bifido infantis strain and they've got a proliferation of the Bifido strains, versus in the right, they pretty much don't have it. Now, the amniotic fluid itself, as you would expect, is pretty much like the placenta microbiome: low richness, low abundance, low diversity, and it's basically, again, lactobacilli. It's got a lot of other bugs in there as well, but focus again on the lactobacilli. And I do think that clinically you can extrapolate and say that for women who are having lower amniotic fluid and they're having a risk of preterm birth and you're concerned about it, flood them with lactobacilli, and I do think that that will increase the volume. And it's probably likely. I haven't seen papers on it, but I've extrapolated and started experimenting, and I think it's a reasonable clinical assumption. This is an interesting one where if the mother's respiratory microbiome, if she gets an infection, it has a direct impact on the intra-amniotic fluid. And so the amniotic fluid, if you sort of map it in your brain, amniotic fluid matches the placenta, which matches the oral microbiome. If it's gone in orally and she's breathed something into her lungs, it's also going to have an effect then on the amniotic fluid. And this is looking at a 17-fold increase of Haemophilus influenza that inducing preterm deliveries from the mother getting it from her respiratory microbiome. We're all starting to see the correlation and every little bit being interconnected. It's pretty full on. Now, I brought these next slides in, obviously, because of the conference itself. I'm not going to cover it in great detail, but lots of meta-analyses correlating infection and increased risk of ASD in the offspring. They multiple hypotheses for it, but there are direct exposures and certainly indirect exposures, and the infections causing an inflammatory change on the developing brain. Everyone in this room would be comfortable with that, but what they're finding now when they look at the analyses of all the papers is that the genitourinary and the skin infections are the greatest risk. So genitourinary, obviously what we're talking about, and making sure that UTIs and BV and everything are addressed appropriately. But skin, I think it's important that you start factoring that into the caesarean delivery population, because when we get to it in a second, the caesarean delivery, the microbiota of the newborn directly correlates with the skin of the mother rather than anything else. Don't underestimate the impact of the maternal inflammation. And again, there's really interesting research correlating the pre-gestational diabetes and the gestational diabetes, and its increased tendency towards picking up the infection, or if there's been a dormant infection, reactivating it, and correlating that with increased tendency of ASD as well. And you're all screening all your pregnant women for CMV very regularly? Yeah? If you're not, you really need to. So far we've got a bit of a checklist of infections that we need to cover, but every single woman in her preconception workup has to be screened for EBV and CMV. And CMV, if she has it in pregnancy, I guarantee you it will be reactivated. Any situation I've seen in patients, it tends to get reactivated if it's like a low level in early pregnancy, and the correlation is deafness. It's not a minor infection, that one, okay? So the level of brain inflammation and then subsequent impact to deafness can't be underestimated. have to protect against gestational diabetes though. Now, the gastrointestinal microbiome in pregnancy obviously changes as well, and the change to that is going to impact a number of variables. But one point I wanted to highlight here was just that if there's a change in the digestive microbiome of the mum, it predisposes her to having insulin resistance and gestational diabetes. And they compared and contrasted the two groups where women with metabolic syndrome and pregnant women tend to have the same sort of microbiome changes. And so then women, when they're pregnant, their increased risk is significant of having disruption there. Everyone's face is a blank. I've lost you. Okay, let's go backwards. In pregnancy, we decrease the diversity in the third trimester. We're all comfortable with that. We get increased levels of lactobacilli. That's protective. In a pregnant woman where it isn't increasing to lactobacilli strains and her digestive system is affected, it increases her risk of gestational diabetes. If she's got crappy diet, she has gestational diabetes most likely, and her microbiome gets affected from the gestational diabetes, and her microbiome causes the gestational diabetes. And if she has the gestational diabetes, then the subsequent effect is to the placenta, first and foremost. Does that make sense? Groovy. There was an interesting mouse study with this. I'm not going to go into it in too much, but no one obviously wanted to do it as a human yet. But what they did was that they took fecal samples and they transplanted them, and they caused insulin resistance in the mice when there were situations of a pregnancy scenario. So they took a pregnant woman and they took her microbiome, a pregnant mouse, and they took a stool sample from the pregnant mouse and they put that into a mouse that was not pregnant, and they caused insulin resistance in the non-pregnant mouse. So an unstable, unsafe population in a pregnant woman can cause insulin resistance in a non-pregnant woman, which means that the stability of that microbiome in the pregnant woman can't be underestimated. Yeah? Cool. All right. Couple slides just looking at gut microbiome and ASD. Obviously, this is all very familiar to this room, so I don't want to spend too much time on it, but just recognise that the gut-brain axis of the infant directly correlates with the gut microbiome of the mother. And all the new research, papers from 2013, 2016, and certainly other ones that have come out since I wrote the talk, the gut microbiome of the mother directly correlates with the gut microbiome development of the child and the gut-brain axis of the child as well. It's a reversible impact. So if if a mum has thrush and it all looks a bit dodgy, you can usually reverse it, but there will be some inflammatory damage. So make sure that you look at it. Now, if you look at the next slide, what we're looking at is that the developmental processes of the neonate within the mother have a direct correlation with the microbiome of the whole person, the mother, the baby, the unit, the placenta, the whole bit. And what they're finding now is that the signalling between all of the different microbiome species around the mother and the baby are basically driven by the gut microbes in the mother. So where the mother's gut microbiome is at will tell all of the other subspecies what to do, including that within the neonate. And what gets exciting or scary is that the gut microbiome status of the mother directly correlates with blood-brain barrier formation of the child, the integrity of the blood-brain barrier formation of the child, myelination. So you're all familiar with that sort of week 18 to 24 of a pregnancy where there's that significant myelination leap, usually correlates with the mother having diarrhea at the same time. Have you all seen that in clinic? So in second trimester, there's that week 18 to 24. It's something that I've worked out a number of years ago. Week 18 to 24, she's always much more tired. She usually has a bit of diarrhea. She can get quite depressed. She's just very flat. You know the time when everyone says you should be glowing? Yeah? So most women aren't glowing. And the reason behind the fact that they're not glowing is partly because of the myelination development of the child. So you've got all of the myelin sheath developing within that time frame. If she's having twins, it's usually a little bit earlier, just a little caveat. So you've got myelination development going on. All of her methylation factors are incredibly essential at this point. Her demand for B12 and folate and all those variables are basically through the roof. And she feels pretty much like crap. The more diarrhea she has, the more disrupted her gut is, the more it actually affects the development of that myelination. So I routinely see my pregnant women at about week 16, 17 and load them up on all these things and give them a bit of warning and tell them to just have 6 weeks of a bit of downtime because it's a really rough period for women. If you haven't seen it, you're going to now, just because I've highlighted. But I actually think it's possibly the trickiest time in any pregnancy for women because there's no social acceptance around it and she's meant to be quite buoyant, but it's actually where all of this stuff is actually happening. So please try and help your women if you can. All of the neurotransmitters and their receptors are also developed at this point as well. So the demand from mum with her neurotransmitter synthesis becomes quite accelerated as well. That's partly why she feels so depressed. Now, if mum is overweight and if she gains too much weight in pregnancy, it has a significantly adverse effect on the gut microbiota of both the mum and the bub. Normal healthy weight gain in a pregnancy, what does everyone think? 8 to 14? Yeah, they say roughly 12 kilos. So in Chinese medicine, it's 1 kilo per month and then 1 kilo per week after 8 months. So roughly you're looking at 12 kilos on average. There is a lot of women gaining a lot more than that. I've got one pregnant woman at the moment, she's gained 27 kilos. Yeah? 27 kilos, I guarantee you 10 kilos of that is fluid because the size of her ankles is just ridiculous. However, 27 kilos, the load on her body, can't be underestimated, and I don't think we have sufficient understanding of that hypothalamic set point of weight that is developed. I think some of it will have to be developed in utero, you know, that hypothalamic set point that people have for their body weight for the rest of their life and all of that. I think some of it will be developed in utero, and I think some of it happens certainly in that second trimester period. We know that when women are overweight, there's a significant change in their gut, in their systemic microbiota, but certainly within their gut. And subsequently, that has an impact on their kids. And with kids, what you find is that if mum was overweight in pregnancy, the chance of kids being overweight later in life is very significant. And there's obviously all the health impact that goes with that. The intergenerational impact through the microbiota and through genetics can't be underestimated in this context. If the maternal body weight basically tells us what her microbiota is, and I'm sure Jason will go through more of this later, the microbiota from obese mothers directly correlates with unhealthy microbiota of kids if it's out of balance. And we know that vaginal delivery compared to caesarean determines if the child's going to have obesity as well. So if a child is born by caesarean section or an IVF baby, we know that they have a higher chance of obesity versus vaginal delivery. You all familiar with that one? No? Okay. So just bear that in mind. So there are obviously pros and cons. We'll talk about delivery in a moment. There are pros and cons with respect to delivery methods, but if mum's overweight, her chance of a caesarean is greater because of all the other health aspects, because of the changes to the microbiota to her vagina and how that will influence, you know, the shortening of the cervix, the opening of the cervix. So she's likely to have a preterm delivery with a baby that's going to be overweight as well. Not a healthy combination. So try and use that 12 kilo rule as a general guideline, but 8 to 14 obviously fine. But it's not about weighing women whenever you see them because that tends to cause a lot of emotional distress to them, more about just encouraging healthy practices and, you know, love and compassion for their own bodies, because if they hate themselves in their pregnancy, that causes maternal stress, and Lauren was talking about that earlier, which isn't good. Okay, so what I'd like to do is deliver this baby. So now let's talk about labour itself. Now, there's an enormous amount of controversy around labour with respect to the sterile womb paradigm versus the infant acquiring microbes during pregnancy itself. I think if we wait another 12 to 18 months, it'll be pretty conclusive that everything passes through the placenta, but I don't think research has caught up at this point. So there's one school of evidence that says sterile scenario, baby's in this lovely little bubble, nothing passes through, and the other body of evidence that says everything and anything goes through the placenta and baby can be exposed to it. I think we're like 95% there with research, but there's still a couple of papers, including a 2017 review, that said that we're not sure. And I went, really? So, lovely visual picture, if I show it to you, sorry. Lovely visual picture here. I don't think that babies are born sterile. I don't think anyone believes that anymore. So I think that there will be a reframing of vitamin K after delivery and all that sort of stuff soon as well, because we'll be able to understand it in a different context. Now, labour itself, we don't have entirely complete understanding of how the bacteria pass to the fetus, but I think that, you know, all the research that is showing, you know, probiotic strains and allergy or eczema in kids passing through and protecting kids and various other studies like that, I think we can understand that the research is sufficient, but it's not entirely proven. What we don't understand, though, is that labour itself is it actually live bacteria that they're actually full of, or is it DNA remnants, basically, of the microbes from mum? And that's the part where science hasn't caught up. What we know, though, is that different probiotic bacteria have different abilities to transfer from mother and child. There's a 2015 study that I highlighted over there, and it showed that, postnatally whilst breastfeeding, there's an abundance of a particular lactobacilli strain there and a bifido strain as well. But there's lots of different strains, and some of them will colonise in the baby and some won't. I was in Japan, I can't even remember how long ago it was now. And anyway, I was in Japan, Yakult sent me away, they did this thing. Anyway, so the head professor of Yakult, there's pros and cons of Yakult. The pros, good research. The cons, it's full of sugar. Anyway, the professor from Yakult, what he said was, we were having a little side chat, because I said, look, firstly, how many teaspoons of sugar is in Yakult? And he told me that it's 7 teaspoons per standard Yakult, 9 in the light one. 9. Anyway, that definitely shouldn't be on your prescription pad. So what he was telling me was that he was involved in a study where they looked at the fecal sample of both mum and bub after delivery, and they basically looked at the mums and different areas which they had delivered in. And what they found was that if there was an animal in the room, a plant in the room, multiple people in the room, whether or not it was a hospital birth, a home birth, whatever it was, determined the types of strains that the baby had. So there were Animalis strains in the infant stool because there was a dog in the room when they were labouring. Yeah? So anything that the baby is exposed to in the labour, and then if there is the potential for adherence and potential for proliferation, that could theoretically have an impact as well. There was an interesting study that came out that looked at the difference between vaginal and caesarean deliveries, and they compared the types of strains at birth and 6 weeks post-birth. I'm hoping that that's legible in your notes when you have a copy of it. If it's not, go have a look at the paper that's on the next slide. It's on the next slide, sorry. This was a highly controversial paper that was released by Nature, and what they found was 6 weeks post-birth, regardless of delivery method, they had the same strains. Yeah. This was the one that kind of threw everything out the water, so to speak, because, for so long we've always been looking at it and going, vaginal delivery is superior. Okay, I don't think there's any woman on the planet, bar maybe a couple people, that, unequivocally say they want a caesarean delivery. Pretty much everyone is comfortable to have a vaginal delivery. A vaginal delivery, we know the health benefits associated with it. But what one of the arguments was that a vaginal delivery meant that the baby was born and then they swallowed all the secretions from the vaginal canal and from the rectum and the skin and, all that sort of stuff, and that set the baby up for life. This paper from Nature basically said 6 weeks after they've been born, it's pretty much the same. Have a think about it. You can like it, dislike it. There's still always going to be a part of me that says vaginal delivery is going to be the best option. But there are obviously medical situations where some people have to have a caesarean, and I think in those situations, it really alleviates the stress and the guilt that those mothers have. So I think that that's something to consider. And certainly the people in this study, they weren't given baby probiotics when they were delivered. So I'm sure that there's a lot that we can do to improve things. But the statement that came out, you can read through yourselves, no discernible effect on the caesarean mode of delivery. There was another paper, though, that came out in 2017, and this was basically highlighting that perinatal antibiotics, maternal dysbiosis, caesarean section delivery and all that sort of stuff predisposes children to inflammation, which increases their susceptibility of disease later in life. So the things that we're doing in labour, be it antibiotics or forceps delivery or ventouse or whatever it might be, that inflammatory process, I think, has to be considered. And again, I think you need to think about the methylation of the mother. So Bill Walsh's information talks about that in first trimester, the methylation of the mother directly determines the methylation of the child. So if mum has great methylation in first trimester, bub's going to be great for the rest of their life because they'll have a blueprint of healthy methylation. We haven't done enough studies, and I do think that the methylation at delivery has to have a significant impact as well, and I don't think there's enough research around it. But certainly if mother is very stressed because of a stressful labour, that level of inflammation, disruption to methylation will have to have an impact to the child. Now, with caesarean sections, I don't think anyone in the room is pro-caesarean voluntarily. Recognise that some of the research around it says 46% higher incidence of allergy, type 1 diabetes and obesity in children. because of its disruption, and recognise, as I said earlier, that if they're delivered by caesarean, their microbiota resembles the skin of the mother, which basically says the concept of seeding, I think, is a good thing to encourage in your patients if they are having a caesarean, be it intentional or not. But the concept of seeding is basically where the gauze is inserted into the vagina before delivery, if she gets the opportunity to, or post, and then the mother swabs the mouth and the face of the child to absorb it. I think that what we need to remember with delivery of the child is basically that their skin is pretty much translucent and is highly absorbable to anything, which is why I'm just going to skip that slide because you can read through that later. When you look at the vernix, so that beautiful coating that covers our children, it's there for a reason. Don't wash it off your kids. Don't have a bath of your child for at least a week after they're delivered. When you look at the constituents of the vernix, it's basically there to protect the skin, to enable it to have all the right microbiome to be absorbed through their skin. Without the vernix, in that sterile context of a hospital delivery where they wash it off within 5 minutes, you're basically leaving a baby there to be entirely vulnerable to everything. The skin is extremely permeable. And if you can correlate that a caesarean delivery determines the microbiota from a caesarean delivery is determined by skin contact, it basically confirms it for you that their skin is absorbing everything. So if you don't remember anything else, just don't wash it off. I'd like to get stuck into treatment and some of the other things to think about. Are we all okay or too saturated? 5 minutes, great. Okay, so what I'm going to do is I'm going to skip through a couple and highlight the good bits, and because of the style of lecture that I do, you've got lots of notes you can read through later. You're going to have a lot of this from the subsequent presenters talking about pre and probiotic supplementation and the benefits and everything. So you can read through all of that sort of stuff later. But what I would like to talk to you about are a couple conditions. Now, glycemic control and gestational diabetes, bear in mind that the strains are quite specific. There are meta-analyses there that can help to improve it in your female patients and make sure that you use it. And the next slide just gives you the references. Whenever you look over my notes, just recognise that I don't number it because it always gets skewed when you send it to someone to upload. It's always in order, so each point will correlate with a study in order if you want to go over anything later. There's phenomenal research looking at preeclampsia and probiotic supplementation, so I think that you need to acknowledge that. Bear in mind that most of the research is around dairy as food, so you are extrapolating to an extent, but there is new research in the pipeline if you do pay attention to it. But there is good research looking at the synbiotics, particularly to inulin, and how that decreases insulin concentration and protects against preeclampsia as well. Allergy is certainly important as well. Preterm birth, allergy can read through later because there's a lot there. But I do think that the depression aspect is something that we shouldn't underestimate. Depression in pregnancy is something that's often not reported because women tend to feel quite ungrateful if they feel depressed. If I ever meet a woman after she's conceived, the first thing she says to me is that she's depressed after about 10 minutes of conversation. It's generally that she's completely depleted, and if it's not her first child, it's even worse. But the microbiome of her body influences her neurotransmitter production and the subsequent production of her kids as well. Now, group strep B, Jason is going to talk about a lot. Have a read through this. The incidence is alarming. I certainly know that complementary medicine practitioners are very anti-antibiotics in labour, and it's not that I'm pro or against. It's a position that you and your patients can take together. I just want to highlight that strep B can kill kids, okay? So it's not one of those infections that you just ignore. You have to have some tools in your toolkit if you're not going to do antibiotics. But certainly if you are going to do antibiotics, make sure you sort out the microbiome because of the risk of ascending infection, which is the most alarming concern. But, preterm birth and certainly death of the child, stillbirth or early death is something that you can't underestimate. Treat them before you get them, though, and that's how you fix it. There's some infection, obviously, with Listeria you can read through, and E. coli. Last thing that I want to really touch on is just talking about the maternal stress, because Warren, I know, mentioned it earlier, but the stress, recognise its impact to the microbiome and how if the mother has a significant amount of stress, she has much greater risk of having preterm delivery, low birth weight, caesarean or rapid vaginal delivery, and certainly low body weight, immature digestive tract, and all the other concerns that go with it. If she's stressed out, give her support. It's normal for women at 36 weeks gestation to start to be reclusive, to start nesting and to pull away from society. That's what all women do. But make sure that you give her the support and that you help with her anxiety levels. It's like a natural nesting thing that they all get a little bit anxious. It's normal. I certainly did. But it's really important that you can settle that down and give her all the strategies that she needs so that you can help to keep the baby in there for as long as possible. I've got a list here of inquiries that you need to ask all of your patients, both preconceptually and during pregnancy. Don't underestimate some other more uncommon delivery systems of infection. Make sure that you ask carefully about sanitary items. There's a lot of weird research coming out about menstrual cups at the moment with increased incidence of staphylococci infection, and certainly contraceptive choices that people have and the incidence of infections. Unfortunately, people aren't very hygienic, and ascending infection risk is quite alarming. So do be careful with that, and then you can have a read through to make sure that you have some other ideas. I've just got in the last few slides just around some other food strategies and topical preparations that you can look at. In summary though, this particular image came from a study and I had to share it because it was from this year and I think it's pretty amazing. And what you find here is that they're looking at the difference in maternal and infant strains and how to improve it. If you've got nothing else, print this one out, download it from the study and just look at it with every particular patient that you see and it'll remind you of some checklist points. I'm sorry there was so much info, but there was so much to cover. I hope you got something out of it. Thank you.